Between playing volleyball and strength training, I am no stranger to shoulder injuries. One time I was showing off in the gym and ended up tearing my rotator cuff. My rehab strategy then, not quite as effective as it is now. Just had a patient recently with a rotator cuff tear, and here's the plan that I laid out for her. So let's walk through the common mechanisms of rotator cuff tears, how you can tell a tear versus a strain, why a lot of rehab programs fail, kind of the old strategy versus the new, what I like to do instead, including what I can do to supercharge recovery with additional peptides and supplements and things like that, how to avoid re-injuring that one, and some red flags that tell you it's probably more than just a strain. But first, I'm Dr. Alex Watson, and I get people ready. By that, I mean I get them ready for fitness-based activities, cancer therapy, surgeries, things like that. I call it rehabilitation. This is part one of a three-part series on common injuries and how we can rehab them a lot faster than we used to be able to. It'll include the common mechanisms and recovery strategies for things like rotator cuff tears, meniscus tears, and bad ankle sprains. We also want to thank all of our new subscribers here. We've had a ton of growth in the channel in the past couple of weeks, and we're really grateful for that one. We're working very hard here as a team, and would love it if you are not subscribed, if you can subscribe today so we can keep that growth going. Makes it a lot easier to make these videos and keep investing some time in this stuff because we're a busy medical practice as well. All right, so what is the rotator cuff? It is actually comprised of 4 different muscles: the supraspinatus, infraspinatus, teres minor, and subscapularis. The relevance here is that they all sit around the shoulder joint, also known as the glenohumeral joint, because the glenoid is the part of your shoulder and the humerus is your arm bone here. They are what we call dynamic stabilizers. So they stabilize the joint in a dynamic way, in a way that allows for movement and provides that stability during that movement. So supraspinatus' main job is to start your arm in abduction, bringing it away from the body. It sits right back here on your shoulder above the spine of the scapula, supraspinatus. The infraspinatus helps you to externally rotate your arm, like this. It rotates your arm when your arm is against your side here, outwards. Whereas a teres minor, it'll externally rotate the arm, but when you're abducted already. So supraspinatus will abduct, teres minor will then externally rotate that one. Whereas a subscapularis, it internally rotates. So that one is not commonly as injured. The supraspinatus is the most commonly injured muscle of the rotator cuff. Usually it's the tendon actually that's injured. It runs from the back of the shoulder here, underneath this knobby part of your shoulder. You can feel it in the front. That's the acromion process. Your collarbone, the clavicle, meets up with your shoulder. Underneath that point is where that supraspinatus runs, and then it attaches onto the deep part of your shoulder bone there, allowing you to start that movement before your deltoid takes over for the rest of it. Why is that relevant? That space underneath the acromion, the subacromial space, it can be narrowed from a lot of things: arthritis, age, genetics, things like that. It also can be dynamically narrowed if your shoulders roll forward a little bit or if they're tilted forward, which is not uncommon in our daily kind of posture in life and gets worsened with certain training styles in the gym. If you're somebody who doesn't focus a lot on that scapular retraction or strengthening your lower trap muscles, and so your shoulders get pulled back down to your rib cage, they're going to start tilting forward and narrow that subacromial space even more, making you at more risk for injury there. If your arm's abducted away from your body here, and then you're putting some force through your shoulder too, all of a sudden that supraspinatus is already impinged, and then now has a force applied to it and can strain or tear. There are all kinds of different tears: partial thickness, full thickness, how long it goes from the tendon back to the muscle, that kind of stuff. Not as important here. The big thing is you strained it, you tore it. Now, how do you fix it? Understanding the mechanisms of injury is really important for preventing that re-injury later by fixing the underlying dynamic component. So if you're somebody who does have, as I'm sitting here like this, your shoulders rolled forward and weak retracting muscles of your scapula, that's one place that you want to start. You can also understand the positions in which the supraspinatus is at a higher risk based on the ways that we test it in the office. One of the main ones that we're doing here is called the empty can test. We're having you turn your hand over like this as if you're pouring out a can of soda. In doing so, you're narrowing that space and putting that supraspinatus in contraction. So you're shortening that tendon and you're narrowing the space, and that puts it under some pressure. And if you have inflammation there already, you're going to feel a lot of pain doing that. So if you are in this kind of position, arms abducted, so arm out away from the body, in front of you like this, you go to catch something forcefully. That's one way that you can commonly strain it. Falls, if you're going to catch yourself in a fall, that can also strain the shoulder pretty badly too. Car accidents, that's actually where my patient last week had gotten hers. But this is an interesting story. So she is somebody who was a house cleaner and then got in this car accident. So when she's cleaning houses, she's often cleaning walls in front of her this way. You may think this is good for strengthening the scapula, but because she's not back here in line with the body, but up here, she may be exaggerating that underlying problem of scapular dyskinesis or forward tilt of the scapula there, kind of reinforcing the problem. Then she's holding the steering wheel, gets in a car accident, and that force can put some strain in that rotator cuff and tear that supraspinatus. How can you tell a tear versus a strain? One is going to be noticeable loss of strength, even if the pain isn't limiting that so much. The body does some stuff where it'll actually decrease your strength due to trying to preserve itself. So if you are injured, even without a tear, you may be weaker because of the way the brain's kind of gating that strength output. But this will be a pretty obvious greater than 50% weakness in that motion. So the supraspinatus being the way to lift your arm away from your body, if you're suddenly lifting half the weight on a shoulder abduction or something like that, that may be a factor. We're going to order some imaging. That's what we're really going to tell about this one. Popping sounds may or may not go along with this in terms of the diagnostic utility here, figuring out if that actually is a tear versus a strain. But either way, unless you're a high-performing athlete, something like that, even if you have a tear, we're probably going to treat it very similar to a sprain and adjust the plan based on your pain and your recovery rate and those sorts of things. So it doesn't really matter quite as much if we know tear versus a strain. Now, a lot of rehab plans focus on strengthening the other rotator cuff tendons, and you may wonder, is that why I'm calling them bad? No, actually, that's a really good thing to do. Because when you strengthen the full spectrum of dynamic stabilizers of the shoulder, that glenohumeral joint will sit more center here. The ball sits on the tee in a much better position instead of pulled forward, back, different directions, that kind of stuff. And so when you do that, you then allow for the correct use of different muscles when you're reaching overhead and things like that. You're doing a lot of pressing activities either overhead or in front of you, or you're doing a lot of pull downs, which actually is an internal rotator, not external. You may end up having a lot of strength in the internal rotation side of things, but not as much in the external. So I actually got a lot of my injuries playing volleyball when I go up for a block and going up too fast, I'm actually subluxing my shoulder joints. So they would slip out of the joint briefly, not dislocation, but a little subluxation. And in doing so, it really irritated the biceps tendon, the rotator cuff, this labrum in both shoulders. And I drove stick at the time. I couldn't even drive stick. It was that painful briefly. Once I learned that lat pull downs were actually not an external rotating exercise and it was internal, I was really just doing one side of the equation, started doing resisted external rotations this way and this way. The pain really went away, and I haven't gotten it back since, fortunately. But you don't want to start there. You first want to start by fixing the movement of the shoulder blade here. You want to make sure that you're able to actually move it in concert with each other and have a right balance between the scapulothoracic movements, so that shoulder blade on your rib cage in the back there, as well as the amount of movement through that glenohumeral joint. So the right balance there is important for not straining your neck, not putting unnecessary strain on certain tendons here, not getting pec minor problems underneath your pec major here. That's another common injury. So certain activities for those sort of things. Wall slides, putting your arms up against the wall and being able to bring your arms up and down in the right plane of movement along with your body. Another one is going to be lying Y raises. So you're laying flat on your stomach and raising your arms up this way, because that allows you to strengthen all of the middle lower trap fibers that are going to help to stabilize the scapula, prevent it from going forward. Also anything going backwards there. You want to do shoulder blade retractions. So you want to strengthen the muscles that bring your shoulder blade back, because when you do that, you're going to have much better control of that shoulder joint. The scapula can be fixed better against the rib cage when you're going to brace yourself, doing things more stable a position, and it'll help prevent injury that way. Now, what else are people getting wrong here? And this is one that is still a very common mistake. That's going to be ice and anti-inflammatories. I think Dr. Mike did a video on this recently, but you want to make sure that you are not suppressing inflammation either after exercise and after injuries. What your body does is it uses inflammation to know where the problem is and how much to react to it. So if you're dampening down that inflammatory signal here, your body's not going to know how big of a deal it is and how to fix it. So you want to make sure that you're actually leaning into the inflammation. So before rehab-based therapies, you actually want to throw some heat on there, get some blood flow in there. It'll both prepare that area for the activity, but also get that blood flow there so it can send those different healing factors, that kind of stuff, all the collagen peptides to build that tendon back up. In the same vein as collagen peptides, someone rehabbing their shoulder should be taking collagen peptides. Because if you take that before the therapy, about 30, 45 hour beforehand with vitamin C, that is the important missing building block for those tendons. So your body will now have the signal from the inflammation and the necessary substrate to fix those tendon fibers. It'll lay down new fibers, cross-link that collagen with that vitamin C, and get you healing better. You want to make sure you're doing this before and then the collagen after as well, because it's so cheap and harmless. I just take it kind of both times to make sure you got all the building blocks you need. Now, another area where the kind of wisdoms change over time is I used to do a lot of eccentric based rehab exercises. Let's use the chest press as an example. This is the concentric portion of the movement. The muscle is shortening as the activity is going on. Eccentric is the lengthening contraction. It is stretching as we're going down, but you're still contracted because you're supporting that weight. Eccentrics is the greatest amount of stress that the tendon can be under during the activity. If it's with a light weight, that's good, but it might be a little more strain and more stress than that tendon can handle right now. And it's actually not necessary. And based off the teaching of Dr. Keith Barr, we learned that a lot of the research behind eccentric rehab strategies actually was benefiting from the isometric portion of that activity. Meaning, by engaging the tendon not in a concentric or eccentric movement, but instead holding an isometric, so you're not moving, position for about 15 to 30 seconds, depending on the injury and the tendon size, all that stuff, you can get better recovery that way. It's also safer because you're not moving, you're not adding that element of, three-dimensional activity here. The injury and the re-injury risk or the worsening of the injury is lower. So it's a nice, safe way to do that, and you do not need a strong stimulus. So for the supraspinatus, I tell my patients just lean up against something. So we'll say this armchair here for this supraspinatus, just push against it. Literally just activate it that way and hold that for about 30 seconds. Change your positioning around a little bit until you feel that kind of warmth in that muscle. That means that you're engaging it and the activity is going to have that benefit there. All right, but hey, you got to get back to sports. You got, there's a game coming up. I would still sit this one out, but say a couple months from now, and you want to be back at tip-top shape. What else can you do? Well, there are interventions that we do on the medicine side, things like PRP or prolotherapies or exosomes and that kind of stuff. I don't do a ton of those, but real quickly, PRP, we draw some blood, spin it in a centrifuge, draw off the platelet-rich portion of that. So that's what PRP stands for, platelet-rich plasma, and then inject that concentrated substance back into the area of injury, because that solution there actually will have additional kind of growth factors. So platelet-derived growth factors and different factors that tell the body, let's send some healing stuff here. Prolotherapy is literally just a dextrose, so a sugar injection. It irritates the tissue and causes kind of a healing response there as well. Exosomes, that's getting deeper into the weeds, something I've never actually done, so I'm just going to leave that to somebody else who does it more often. But say you don't have access to that, or don't have access to the several $100s that a lot of those procedures cost. Well, there are things that I do instead. So on the peptide therapy space, this is where everyone's talking about BPC 157 and TB 500, the Wolverine stack. The research is mostly preclinical, so not in people, unfortunately. It's kind of in a lot of animal models, but does have this kind of cult following in terms of its ability to heal musculoskeletal injuries, particularly rotator cuff, kind of shoulder joint injuries. That's one approach. You can more broadly use peptides that just generally help recovery. So things like growth hormone type peptides, things like your tesamorelin, ipamorelin, sormorelin, CJC 1295. Those will increase the growth hormone release, and more growth hormone is a supportive for healing because it increases the amount of collagen that your body's producing. There is some argument to pair the two together. So pair one of those growth hormone related peptides with the BPC 157 because BPC may increase the expression of growth hormone receptors on injured tissues. So it gives you kind of this localizing effect of the increase in growth hormone to the site of the injury where that BPC is kind of tagged already. Obviously, that's not very well proven yet, but that's the prevailing wisdom. But the number one most important thing that you can do to supercharge recovery, prioritize sleep. Sleep is the most important thing here because that is when your body is releasing the growth hormone anyway. So you can take all the peptides that boost it, but you might as well do the foundational stuff to do it yourself. Also, sleep in general is when your body's rebuilding, obviously. And if you were shortchanging your sleep or, impacting the quality of sleep due to alcohol use or, too much cannabis before bed or other deep sleep and REM sleep affecting medications. Try and winnow those down a little bit because you want to do whatever you can for the best quality of sleep for recovery. You also want to fix anything else impacting your muscle anabolism, so building muscle, which, is kind of synonymous with get your testosterone up. If it's low, bring it up. Do you bring it up even higher, even if you're normal, just to see if that helps? That's between you and your doctor, but it is something that some people will do in this sort of situation to accelerate recovery a little bit. Back to that avoiding re-injury. So you fix your shoulder blade mechanics, meaning that you're now going to put no additional strain in a precarious position onto your rotator cuff tendons. What else can you do? Well, ease back into it. So once you've done the isometrics and then you've done the eccentrics under slow controlled settings, then you kind of return to sport in a sport-specific way. Moving on to the red flags. What is a sign that this might be worse than you think? Look up the supraspinatus again. I think you strained it, but you got this nagging night pain. Really terrible when you lay on your side there. Or you were just very weak, even beyond pain limited. Like I said before, that weakness is going to indicate more likely a tear than a strain at that point. And the laying on your side pain, that may imply a little bit of subacromial bursitis. So the same space, that subacromial space, there's a bursa there. There's bursa all over your body. That is a place of potential friction between moving tissues, and it cushions that space. Well, subacromial bursitis is a very common pain there too. So you can get all kinds of different sources of pain in the same location, full of fluid and inflamed. The last thing it could be when you're laying on that right side and there's that pain there could be a sprain of your AC joint. So I mentioned that earlier. That's your collarbone and the acromion process there. So when you put those together, that's the AC joint. That's held together by ligaments. In this case, if you've sprained one of those ligaments, then you can have that pain as that joint is compressed laterally. So you're pushing this way, compressing that joint. It can cause additional pain that you're not going to feel when you're standing up usually, but it does create some pain if you're kind of crossing the body. So we do something called the scarf test there, and it might recreate that same pain. All right, so let's do a rapid fire recap here. Number one, make sure that your shoulder mechanics are correct. Most of us do not have healthy shoulder mechanics, and it takes a little bit of diligence here to strengthen the retractors of your scapula, middle and lower traps, as well as the serratus muscles to keep that scapula, the shoulder blade, back against your rib cage when appropriate here, and a balance in those rotator cuff muscles. So I make sure that you're really focusing a lot on those external rotators like the infraspinatus and the teres minor. Infraspinatus, teres minor. You look like a T, teres minor. By strengthening in both those planes, you're going to help to give the shoulder enough control over itself that when you're going in different movements, you're not going to suddenly sublux out or bear a load in an unstable position, causing an injury. As you fix the shoulder, focus on nutrition, collagen peptides, vitamin C beforehand, no vitamin C after exercise because that has some anti-inflammatory effects, which you do not want. Otherwise, pain control should be with Tylenol and avoid NSAIDs around rehab times because that might suppress that inflammatory response again. Isometrics are where I start for the rehab exercises and then progress into eccentrics, so a controlled movement where you're letting the weight down under control is the next move there before you go through full ranges of motion with heavier weight and sport-specific exercises. You want to make sure you're working with a physical therapist because everyone's a little different here, and making sure you do this correctly for your particular injury is obviously an important thing to do so you don't waste your time, but also don't risk injuring something else or worsening your current injury. Peptides can help recovery, but they're not going to replace the basics. Get your sleep, make sure that you're eating well, make sure your stress is managed, and that you're continuing to stay active. Don't become sedentary because then you have bigger problems. Do not rest that shoulder. If you're not telling the body where the problem is and which direction the fibers run, it's not going to heal it correctly, and you get this chronic shoulder pain for long term. You want to make sure you're engaging as early as you can, safely, and under supervision. Thank you again for watching. Please subscribe if you haven't already. Again, it really helps us out here. I will see you in the next one of this series. Thank you.